that's Stephen's wallet,
Oh,
the
I'm sorry.
robot thing. That's doesn't count, I'm afraid.
Gotcha.
Yeah. No, that was. I've still got to tidy up a little bit with the getting some. All my cards are cancelled, but I need to order new ones now. And apparently in Germany, and I didn't know this, and I'm the same with you, John, but it's a matter of law. You have to report it to the police that you've lost your passport or Ausweis identity card. So that's something else to do next week as well.
Oh yes, yeah. I think you do here too. Yeah.
Yeah. Okay. And Steve, have you got your questions lined up for Dr. Murray? Yeah, last time you said to me.
No, I'm doing what he suggested, which is disengage from doctors. Apart from the NHS had some pod out of me arm this morning, so let's wait and see what that tells us.
All right. Yeah, a bit early days.
I've got my script ready it's for the lipid clinic, which is basically the statin salesman who says LDL statin, and I'll say no.
Right.
I've got my script ready where I'll say, yeah, but look at my trig HDL ratio. It's gone 1.8 down to 0.5. So I'm not worried, and talk to me about particle sizes or numbers and all the rest of it, and I'll listen to you. Before you talk about LDL, you're incompetent and corrupt, so you.
All right, Steve. All right, they'll kick you out the door.
They've already supposedly done that, but then I still get a letter saying come back every year for another set of numbers, and we'll have another go at selling statins to you.
Was that a question, Linda? Because Mr. Murray, Dr. Murray, is about to join us now. Go on.
I was just going to say that I went to the drugstore the other day for a different prescription, and the pharmacist came over and said, the insurance company wants to know why you haven't filled your statin. So I can't just fill it. They're watching me.
It's interesting that they are watching you. Hi, Scott. How you doing?
I got an email yesterday too from the insurance company.
One of the things that's one of the things that's always fascinated me is that they write prescriptions for me, but nobody actually checks whether I'm going back on a regular basis to cash in those. You know what I mean? No one knows whether I'm taking those pills or not. You'd think they'd say, oh, I've just Mr. Phelps did a 3-month supply of whatever Ramipril. That means he should be coming back every 3 months.
They don't trace me either. So thank goodness.
It'll come off your social credit score, mate.
They're checking on me.
They've got Linda's in what they call it. Linda's in the crosshairs. How you doing anyway?
Just fill it and then they'll leave me alone.
How you doing, Scott? Anyway, here you
fine.
go.
Can you hear me?
Yeah. Thanks for joining us. Right. Thanks for agreeing to join. That's fantastic.
Great. Good to see you all. Some familiar faces on here.
There are, yeah. You've got mostly the hardcore here.
Hardcore. The proper ones.
The troublemakers.
The troublemakers is even you say, that one of those they've come from that bunch of troublemakers again. And of course, Steve is also one of your regulars, I believe, or at least
Steve, yeah. How you doing?
He's had the advantage.
Thanks, yeah. Whatever's been done so far, it's working.
Oh well, okay, good. So I was thinking about what to do. Some of this might be irrelevant to you guys, but there was a talk that I did that was short for British Society of Cardiovascular Imaging earlier late last year actually, and it was about whether calcium is important or not in what was particularly asymptomatic patients. Now, a lot of you guys are beyond that realm because you've already had symptoms and been through the ringer, I suppose. I don't know whether, but there's a couple of little concepts in it that I'll pull out, and then we can maybe just have a bit of a Q&A.
No, cool.
Is that all right?
You should be able to share. I've just
share my screen. There's 2 screens here, so hopefully this will work. Can you see that?
Yeah.
Looking good. Let's just see that it works. If I pop this up here.
Oh, that's an interesting topic, Scott. Actually, something we often talk about.
Yeah. So I mean, even if it doesn't, what I might do is just jump to the stuff that's relevant for you guys. It's only a short talk anyway. So I was asked to do this because there was someone in the the other side of the many debate saying that calcified plaque, you know, wasn't important. And what I was trying to point out is, if you see where this arrow is here on the first slide.
All right, yeah.
So this is an artery here with contrast in it on CT, and what we've got here is a bit of calcium at the start of the plaque, and then you've got the soft plaque element here in the middle, and then you've a bit of calcium at the edge of the plaque. And people can be asymptomatic with this because there's actually enough room for blood to get around the plaque and get through the artery. But the major concern is this area here, particularly this bit here, which I don't know whether you can notice with the resolution, but this is slightly darker. And this is the softest part of the plaque. This part of the plaque here, although it's not calcified yet, is probably calcifying and is probably fibrosing as we speak. And then this bit is already calcified, and this bit is already calcified. You can imagine
upstream there, and does it matter?
Yeah, this is upstream and this is downstream. Yeah. So you can imagine the wave of blood pressure comes down here with every beat, and if it crashes off here, which it will do to some extent, this has already started to sort of solidify itself in order to protect that, and the stress on this area of the plaque would have stimulated this to some degree. But this area in here is a concern, because as the wave comes over here, the worry is that there'll be at some point increased stress on this part of the plaque, enough to either erode the lining here or to split the lining here, causing this to leak out. So this is just trying to give an insight into the fact that plaque, we see the calcium and calcium score test, but there can be another almost like iceberg underneath. So I had to give my disclosures to that talk. Now, what I said was that coronary calcium is Janus faced, and what I mean by that is that it's looking to the past, as to what you've done in your life before, your genetics and your environment, and your risk factors, but it's also looking to the future, as in what is ahead of you in terms of your risk. So that's why I'm such a proponent for, you know, calcium scanning and CT scanning of the heart, because we can see the plaque and we can see what still is yet to be calcified and what has calcified. And so I'm saying that this is it's a prophet of those to come and the harbinger of a greater friend. So I think calcium is useful because it tells us what's gone before and what may come in the future. So we can see the threat, but how do we avoid the catastrophe? So we can see this bit sticking above on a calcium score, but in actual fact, underneath all of this, there could be soft plaque, but not just the soft plaque. It's the risk factors that have got you there in the first place, as well as the genetics and everything that we still don't know. We published this case report in the BMJ in 2017. Where a vulnerable plaque was seen on a CT angiogram about 6 months before a patient went through a knee operation. And in actual fact, what happened was the patient pitched up with a heart attack after the knee operation. But obviously the plaque wasn't bad enough on the CT scan 6 months before to do anything about it. So nothing was done, and it was a nod to, you know, what should we do when we see this. So you guys will be aware of this. So coronary artery calcium burden and instant sudden cardiac death. So if your calcium score is greater than 1,000, although there's some wide confidence intervals here, the event rate is much higher than if your calcium's 0. And this is your sudden cardiac death event-free probability according to your calcium burden. Again, it's just that graph turned on its head in a way. Yeah, this is all stuff that you know from being in Mark's group. So I agree with Karim Nazir and these chaps about the role of this. Obviously, if you take asymptomatic individuals from the general population, this is with diabetes, and you do a CAC-based personalized risk management, the people with CAC 0, they can stay on their standard management of healthy lifestyle. But if you're higher risk, then that there needs to be a conversation about intensifying not just their personal lifestyle, but also when we can use drugs to help. And obviously this is a drug heavy slide in terms of what is available to be used. Now, the reason why I think, again, why it's useful, this is a trial from the Netherlands. This only came into press in September 2023, and this is premature atherosclerosis, an analysis over 39 years in the Netherlands. So this is young individuals who were in high-risk families. So individuals with a family history of premature cardiovascular disease, high-risk families, maybe at increased risk. This is instead of just putting through the standard Framingham study or risk or JBS3 or Q risk in the UK, if you actually take the people from high-risk families and you look at them, ProCam is Netherlands version of Framingham or Q risk. So when you use that, you detect less than 1/10 of an actual cohort of patients you could treat. But when you use calcium scoring, if the calcium score is raised at a relatively young age in a high percentile, you can actually drill down and get much more patients treated and identified in these families. And one of the reasons why it's interesting for me anyway to look at this is something we published way back 2014, and this is intracoronary images of twins. One twin had a cardiac arrest and spent a period in ITU, a bit like yourself, Mark, running on the side of the road. Was 8 miles in, can normally do a good 15-miler, and arrested at the side of the road, was resuscitated by a nurse and taken to intensive care. And this is twin one here, T1. This is what he had left after the heart attacks. He'd actually reperfused this area, but we were thinking about stenting this, and we didn't in the end. We just left it alone. We went in and looked at it with some intravascular imaging. Sorry, down here, twin one. Mm-hmm. So what you can see here is that this is the plaque rupture site. So this is hanging in the wind, in the breeze. This bit of thin cap. Oops. This is the plaque, and this actually in here is thrombus. So this is outlined in yellow. This is where the clot was. Obviously, it had plugged his vessel, but because he received aspirin and various drugs, this sort of settled down to this. And you can see here the red stuff is high-risk plaque that was in his artery, and this is obviously the clot, and this is what's left for blood to flow. Now, interestingly, his identical twin brother came to visit him in the hospital, and I said, "Have you had any symptoms?" He said, "No, but I mean, they were monogenic identical twins." We managed to convince him that we would look at his arteries just in case. And what we found was this, and this was on CT. So we put him in a CT scanner first, and we found this soft plaque basically sitting in a very, very similar position, just one artery next to his brother. So it's not really that, you can't really see it on an angiogram. Invasive angiograms don't really show it, but it's actually in here. And this is what it looks like on a CT scan. And this is why I moved to doing CT scans to some extent. You see more disease on CT. Now, we actually did the same thing and popped a catheter into his artery. This should actually say T2 there. And what you can see here is he has the same lesion as his brother, but actually he's just still got the thin cap, right? It's still covered, but he's got this soft plaque in here. And this is it on an optical coherence tomography. This is another invasive imaging. And what we see here is this soft plaque. And right here at this edge, this is what he's got left that's saving him from rupturing this plaque. And this bright line here is the macrophages and the inflammatory cells that are actually in there, sort of chewing away and eating up what's going on in his plaque. And this is the residual plaque that we see here on his IVUS. So these are two complementary techniques. But what you see here is that he's almost there in terms of having the same event as his twin brother. And what we found was that both of their triglycerides were 4 with an HDL of about 0.9. Both had high LDL. And they both avoided stents, but were put on medical treatment for their lipids, had the dietary talk, told to warm up, one down, take it easy in terms of starting and their physical exertion, and not to do anything from 0 to hero right off the bat. And they're both still alive without any further heart attacks. So twin 2 didn't have a heart attack in the end. So this is just basically a cartoon of what we've seen on the 2 previous slides, but it is, as always, more complicated because there's shear stress, there's various signals going on inside here and inside the plaques regarding what they're going to do, how it's going to be managed, and this is how you progress from basically low risk plaque to high risk plaque, and how you end up having an acute coronary syndrome if things don't go well. So as you know, I'm interested in the genetics, the environment, the family cues, and the habits. And I think that a lot of it is preventable, but some of it is not. So we see here your genetic information in the middle. There are a lot of people who are on this side of the lifestyle curve and their environment is very good. There's a lot of people on this side of the lifestyle curve and their environment is bad. I would say that if anything, twin 2 was more on this side than twin 1. He tended to be, much sort of fitter. But ultimately, what determines a lot of it, probably 50%, is genetics. And if you split this up into this non-lifestyle genetic risk factors that we kind of know about, and the stuff that is primarily lifestyle, diabetes, pre-diabetes, abnormal lipoproteins, oxidation, inflammation, all of this stuff, you can see that this is why it's sort of 50-50. There's stuff we can't do much about at the moment because we don't have gene therapy. So for this cohort of people I was speaking to, I was trying to point out to them that in actual fact, there is evidence out there that from the Women's Health Study that type 2 diabetes is a much bigger risk factor than LDL cholesterol, and particularly lipoprotein insulin resistance, along with this metabolic syndrome, type 2 diabetes. There's no way of getting around the fact that hypertension and obviously the other factors play a role. And you guys will talk.
Risk factors there are essentially the same thing anyway, aren't they?
Yeah.
Type 2 and metabolic syndrome and
so
arguably hypertension and certainly obesity are all the same thing.
Yeah, so you get hypertension because of diabetes and metabolic syndrome. Yeah, and you get lipoprotein insulin resistance, raised triglycerides, apolipoprotein problems, inflammation, all because of this. Yep, entirely right. I won't language on this slide, but it's basically everything we've talked about in the groups in the past about how just being energy toxic and sedentary can lead you down a bad path to create coronary artery disease through various methods. And that it is complicated to some extent. It's all of these things: endothelial dysfunction, oxidative stress, insulin resistance, inflammation, that leads you to form each one of these elements that can all interact, and that's how you end up with the event. The only point I'm making in this slide is that only in recent years have we started to pay attention to what's going on in the vessel wall, we've focused for a long time about what's going on in the bloodstream and in the plaque and how you burst a plaque and you make a clot, etc. We're starting to get a bit better at actually looking at what is a healthy vessel, and PVAT stands for perivascular adipose tissue, and whether the actual blood vessel itself is happy, because it's got its own blood vessels. And we know that as you progress to endothelial dysfunction and to atheroma, that there's a stepwise deterioration in how unhappy your perivascular adipose tissue is as well. And we're now able to see that on CT scans. And that is essentially looking for inflammation in the perivascular adipose tissue, because we know now that it's not just about what's on the inside of the blood vessel flowing out, it's also about what's on the outside of the blood vessel flowing in. And this can lead to various problems in terms of vasoconstriction and vasodilation, spasm, microvascular issues, signaling. And being able to see this is a new technique that has been developed out of Oxford, where we can tell whether your perivascular, so again, this is a coronary artery on a CT scan with a bit of plaque here. We can tell whether your arteries are inflamed or not on the outside. And this is two different sets of patients. This patient died of a heart attack due to a proximal LAD occlusion. But you see here in the proximal LAD only had a mild plaque at that point, but their inflammation markers were very high, whereas this looked pretty good for this patient. Patient didn't experience any adverse events during 11-year follow-up, but they had plaque but didn't have any events.
So Scott, is that sorry to interrupt, is that clearly
this
software
is Caristo.
Caristo, okay.
Caristo, yeah.
Is that something that's used typically in your practice, or is that something more experimental?
No, it's something that's becoming more widespread now, due to the sort of level of evidence that they've gathered out of Oxford, using sort of worldwide large data, and applying Caristo to CT scans and following the patients up to see what happened with events. Yeah, so it's percolating into the UK. It should be available in the US. I don't know whether it's covered or what happens with insurance and things out there.
What's it called?
It's called Caristo, 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 and it basically is a CT scan that measures your pericoronary adipose tissue attenuation and looks for whether your blood vessel is healthy or not on the outside and inflamed or not. And we see here when they did the this was in 2022, they looked at low attenuation plaque burden, i.e. on the inside of the coronary arteries, this low attention sort of soft plaque, and pericoronary adipose tissue attenuation. These were the only two independent variables in the multivariable analysis. So down here, calcium score, obstructive coronary artery disease, total plaque burden didn't fare very well, cardiovascular risk score. So this seems like we're trying to move forward in terms of getting there earlier and being able to look at whether the vessel is happy or not, whether inflammation is present, and if we can, and whether soft plaque is present, and if we can get that early enough, we can hopefully change the patient's direction in terms of their risk factors.
So let me just ask you a question. So you see somebody that's got very inflamed arteries. What kind of treatment do you use for that?
So there is an element of this that is trying to push the inflammatory anti-inflammatory model of what I'd call the medical industrial complex. So they're trying to use anti-inflammatory drugs like colchicine. There've been trials looking at drugs that interfere with your immune system to try and help with this. I think personally, you need to look at the patient and determine whether they're inflamed for what reason or another from their lifestyle. and from what they're doing, because the majority of these patients will have elements of energy toxicity in some form, be it that they're over consuming or be it that they have been born with a more lipodystrophic sort of phenotype where they store fat more viscerally, and that fat is more likely to get on the heart, around the heart arteries, and get oxidized and inflamed. So I think it would start with looking at the patient and making an assessment. This is why high sensitivity CRP had turned out in the past to be a useful marker, because it looks at low grade inflammation. And we suspect that the low grade inflammation we've been seeing is what's going on in the coronary, pericoronary adipose tissue and around the heart. I see fat around the heart all the time on CT scans these days, and it tends to be more prevalent. We've published work on it in people who have coronary artery disease, have higher calcium scores, but have more visceral fat, more fatty liver, more epicardial adipose tissue volume. So there is definitely a correlation between being fat on the inside and developing coronary artery disease.
But other than lifestyle, there really at this point isn't much you can do.
Well, no, you can massively reduce your visceral fat by changing your lifestyle. We've actually just shown that a prehab course with basically an element of fasting along with higher intensity exercise in the morning, fasted, can massively reduce your visceral fat. So I think in the future it's about trying to get an idea of how fat someone is on the inside and how inflamed someone is, and looking to reverse that in the first instance. If someone doesn't have objective evidence of coronary artery disease yet, but has a high risk. So it's about how earlier in the pathway are we going to go. So here,
that sounded like me on my bike on a Wednesday morning until you said it not had your event yet.
Right, yeah. Is that what you were doing? Fasted exercise on a bike?
No, that's what I do now.
That's what you do now. Right.
That's trying to head off heart attack number 2, not heart attack number 1.
Yeah, yeah. So just want to make
the question: do you routinely measure visceral fat when you do a CCTA? Do you automatically get a measurement of that? And
no, we've got a research tool called QFAT, which allows us to measure epicardial adipose tissue for research purposes, which we've published on. But what we tend to do is we tend to comment on the degree of epicardial adipose tissue, having seen it a long time, as to whether it's mild, moderate, or severe. We'll also look at the liver in most cases if you've got a non-contrast scan, to look for fatty liver on a non-contrast CT by looking at the Hounsfield units in your liver and determine whether your liver's fatty or not. Okay. I'm sorry.
I was just going to say, let's try and save some of the questions, because I want you to finish your little talk there, and then we can
I'm
go
almost
Q&A.
done here actually.
Good.
I'll skip a few. So just wanted to say a bit about endothelial dysfunction. It comes just because of hyperglycemia and insulin resistance, and that affects on the endothelial cell. And obviously it can affect the vascular biology and determine whether you're going to dilate or constrict, or reduce adhesion of molecules or increase adhesions, and affect the vascular smooth muscle activation. So endothelial dysfunction is one of the 3 arms of the stool. You guys have gone through this, glucose, and whether your muscle, liver, and adipose are full, and how you get diabetic and how you get energy toxic. So I'm not going to spend much time on this. This is a study that was done in people who had had a heart attack. They came into rehab, and this was Aspire 3 in the UK and Europe. And what they found was that more than 30% were self-reported diabetic. When they were retested, this is what they found. Genuinely, only 28% of the people were normal glycemic after a heart attack. More than a third were diabetic anyway, but we found impaired fasting glucose, impaired glucose tolerance, and new diabetes in up to 25% of patients. So you could say that 72% of people having a heart attack were dysglycemic anyway. Obviously, you guys know about triglycerides and HDL. There has been multiple studies looking at that if you have metabolic syndrome, then you're going to worsen your calcium score and you're more likely to have coronary artery disease and progress coronary artery disease. The Miami Heart Study again showed that the independent predictors of plaque, stenosis greater than 50%, were older age men with diabetes who used tobacco and were overweight and obese. Yeah, so when we take in the metabolic aspects of this, there's been a recent study in Korea looking at young adults who have non-optimal lipids and are statin naive. So they just had a look at calcium progression in young adults in Korea. And what they found was a stronger associated was noted between triglycerides and calcium progression rather than LDL-C, which is regarded as the main contributor to coronary atherosclerosis. Since evidence is stacking up and that the key initiating event in coronary atherosclerosis is the retention of LDL-C in the coronary artery wall, lipid management is primarily targeted at lowering LDL-C. The strong predictive value of triglycerides, considered to have a low clinical priority so far, could explain the residual risk as well as serve as a role. Now, I believe that the triglycerides here are just a marker for poor diet and poor health and metabolic syndrome. It's not the triglycerides that are causing the actual coronary artery disease. It's just a sign that those kids were metabolically wrecked and they get the worst calcium progression and the worst ultimate outcome from a coronary perspective. Now, it's complicated, as you guys know to some extent, about how remnant lipoprotein metabolism happens. If anyone wants to chat through this in more detail, we can do it in the Q&A. But essentially, as you know, HDL and LDL can transfer cholesterol between each other. And that's how ultimately you get to a point where a particle gets down to its smallest form, which is LDL in health. And when you're not healthy and metabolically wrecked, you get down to this small, dense LDL that has to get back to the liver through a scavenger receptor, and it isn't picked up by the normal LDL receptors. And a lot of this clearance of these lipoproteins is linked into what ApoE genotype you are, as to whether you're going to clear your lipids well or whether they're going to hang around a lot longer. But we do know that, going back to the triglyceride thing, that if your triglycerides are low, on the whole, your LDL are likely to be a larger, more buoyant pattern, whereas if your triglycerides are high, you're more likely to have this small, dense LDL that has to be repurposed using a scavenger receptor. And this is the difference between a healthy and an unhealthy heart in terms of what we talked about with perivascular adipose tissue and epicardial adipose tissue. I mean, obviously these are both unhealthy because this one, they're on the slab. But
I was going to make that remark.
This is clearly a young fit person who's died of non-cardiac cause, whereas this is someone with a heart transplant probably, or someone who's died who's got extreme fatty heart. This chap came into my clinic, agreed to have his photographs taken. This is what we saw in his echo, global layer of adipose tissue seen. So there's fat here, he's fat around his heart. This was a CT scan, so this is what I see day to day. This stuff here around, this is the heart here. This stuff here around the heart is the fat around the heart. And this is his coronary artery. So this is his left main coronary artery, which is already, let's say, 40% narrowed with a calcified plaque and some soft plaque around it. So he's already on the path to having something quite significant happen. And what I told him to do.
How old was he, or how old is he?
He was in his 60s.
Right.
Yeah. So I told him to do this as an initial thing, which he did do. But government has a role to stop endorsing this sort of stuff. I explained to him about how he could he was diabetic. We explained to him what we could do in terms of if we move to this sort of advice, and actually in 2 weeks, from the 10th of January to the 24th of January, he was able to take his time in range from 100% off target to completely on target.
Wow.
Sorry, Scott, did he
Wow.
know he was diabetic, or you diagnosed that he was
No,
diabetic?
he knew he was diabetic, but he just didn't know how to manage it.
Okay.
So obviously we want to promote exercise within people, because obviously it improves a lot of the stuff we've just talked about in terms of metabolic syndrome. In terms of what you can achieve, and this will be useful for the group to hear, if you stop smoking, the hazard ratio of 0.63, that means that you've got roughly a 37% reduction in your risk of heart attack. Okay. Dietary change, 31 to 28% reduction in heart attack. Weight loss, 18% reduction in heart attack. This was all-cause mortality. Physical activity, 14 to 20%, depending on how much you do. Moderate intensity leisure time, that study was in. But stress management, look at this, 41% reduction in
There
heart
we
attack.
are.
So for all you stress heads out there,
Yes.
type A stress heads,
Mhm.
that is more than quitting smoking.
Mhm.
Although if you smoke, you should quit, but you need to look at stress as well. Okay.
Interesting.
So I'm going to wrap up. Calcium's an important signal, but it might be too late. Don't wait. Something needs to change, because nothing magic's going to happen without change.
I like
All
it.
right.
Cool.
Happy to
Thank you.
take some questions. Yeah.
Yeah, excellent. Thanks. If we can, I know there's some of us who haven't quite mastered it yet, but if we can, if you want to ask a question, if you could raise your hand, digital hand rather than physical hand would help. There we go. Jim, I think you're new to the group, so welcome, first of all. You're on, Jim. Can you talk? All right, so he's raised his hand, but I can't hear anything, Jim.
He's out running.
Jim, we can't hear you, so Marsha, you also need to unmute yourself. There we go. No, yes.
Oh, I'm sorry, my dog's about ready to bark at someone at the door, but I'm not sure, Dr. Murray, if you can see the chat section. I had placed the results of a echo stress test I had done, and then I also had a CT angiogram, which showed in some arteries just mild disease, nothing major blocking. But what I'm concerned about is the abnormal wall motion that they talked about and having ischemia. Is there anything you can do, whether increase your activity? My diet's already really good. I don't do carbs and sugar, but I just don't know, or is this just a defect in the heart itself?
This was during a stress test, was it?
Yes, correct.
Yeah. And did they look at your arteries and say that you didn't have a lot of disease there?
Correct.
I mean, what this would probably make me think of is that there might be an element of microvascular issue here, so small vessel, which is more common in females. And there's a bit of work that's shown that we used to do exercise tests on everyone, and without the echo element, we just used to put people on treadmills, and we would see their ECG change. And particularly if they were a middle-aged female, we'd say, "Oh, that's just a false positive." That doesn't mean anything, and just take you off and reassure you. But I think work is moving towards stating that, in actual fact, it's a very strong marker of whether there's an element of microvascular dysfunction going on there, and that it's not the big pipes that are the problem, it's the small microvessels in the heart. And at any one time during the heart cycle, 2/3 of the blood is in the microcirculation. Only 1/3 is in the major coronary arteries. So what I would probably say is, I mean, obviously I'm not your doctor, but I would say that you need to talk to your doctor and your cardiologist about microvascular dysfunction and whether that is the cause of the abnormality on the stress test.
Okay. And do you find that increasing exercise helps this or not so much?
A lot of the people who have this are can get benefits from exercise, but it can be rooted in the fact that you have an element of endothelial dysfunction that's there. Exercise helps with that. Dietary, changes help with that. But I think the next thing for you really would be, are you having symptoms? Do you
No,
feel your chest tightening?
I do not. I do not.
Okay.
I do have a history of family history of lupus. Could that be associated with this?
Yeah. Any sort of autoimmune condition within your family history? Have you been tested?
I have, and
Or
each year
autoimmune?
it's getting a little closer to positive, but not
Right.
fully yet.
Okay. Yeah, it could be. I mean, there's not a lot of work done on this in terms of separating people out as to whether they have an autoimmune sort of element to that. I wouldn't be concerned for you as long as the main arteries are relatively clear. But you said that there's some plaque there, is that right?
Mild plaque, they said.
Okay, okay. I think probably one for a longer conversation if you wanted, rather than in front of everyone on a group. Yeah.
Yeah, sorry. Sorry, Scott. I forgot to mention, of course, that Scott also does. Dr. Murray also does online consultations. Shout out to Chris, by the way. Nice to see you there, Chris. We ought to catch up, right? Good to see you. But yeah, Scott
Thank you,
also does
Doctor.
online consultation as well. In fact, a couple of the people who've taken advantage of that are here as well. Hi, Chris. James, you're up. Nice to see you too, James.
Hey, Mark, nice to see you too. So in reducing visceral fat, you were recommending, or you say that it's effective to have high intensity training for people that haven't had an event. Do you still recommend something like that for those that have had an event? And how does that change for fasting or not fasting?
Yeah, so there's work done in the UK. It was a trial called Hit or Miss, which was high intensity interval training versus moderate intensity steady state in terms of cardiac rehab. So people had had events, and actually they didn't show that much difference. We've showed in a pilot study that if you do a bit more high intensity and practice fasting, then you get a quicker reduction in visceral fat, and that tends to fit with the idea that you're expending more in your but for someone who's had an event or has precarious coronaries, anything is worthwhile. Do you know what I mean? It doesn't have to be high intensity. It just
Is
has
there
to
a
be.
point that you're kind of overdoing it, that
Yeah,
you
when
should be doing lower intensity?
Yeah, I
Because
would say.
well, for myself, I've recently taken up mountain biking, and I don't do the easy stuff. So
Okay.
I've been running a heart rate of around 175 for
Ooh.
extended periods of time. Is
Okay.
that a bad idea?
How old? I don't want to ask you how old you are online, but are you 220 minus your age? Are you going beyond your maximum heart rate there, or not?
I'm 43 right now. Well, I'll be
Okay, so
43 in July.
What I would probably say is once you switch to things are burning, i.e. your muscles feel like they're burning and you've gone beyond your anaerobic threshold and you're utilizing lactate, that it's probably time to sort of settle down a bit and reduce the heart rate. It would be better to be in that 75% of your maximum heart rate zone and to be able to still almost sort of zone 2 or whatever, still hold a conversation, but struggling a little bit to hold it, if that makes sense. As soon as you go to the point where you're puffing and having to either consider stopping, or that's probably time to wrap it up. In cardiac rehab, we tend to push people as much as we can within their limits, but often not beyond 75% of the target heart rate.
I was going to say, James, get an e-bike for those for that, you know, take off the top 20%.
Yeah, that would do it.
But the fact that you're doing something is good. The thing we haven't touched on is that when we talked about stress reduction as being very important in reducing cardiac events, if you're stressed and you're chronically stressed or you're overtraining, you will raise your cortisol levels, which will make you preferentially store fat viscerally. So, you know, not sleeping well, not de-stressing, overtraining can make you have abnormal cortisol responses, which will make you, you know, more likely to develop high blood pressure and visceral fat.
That cortisol thing's an interesting one. Maybe we'll get a chance to loop back to that. But I've just realized that it's not Jim's phone, it's Faustina. I don't know if you can
Yeah, I'm out for a walk, Mark. It's raining and it's Ireland, and I'm covered up because it's kind of like raining. But what I wanted to ask, well, I wanted to ask Dr. Murray about the intensity, the intensity training. So he's kind of covered some of it, but I'm just wondering, what I just want to just kind of want him to clarify. Is it in a fasted state in the morning, or is it just that he means like the intermittent fasting, you know, for the for the exercise, you know, for doing the exercise, or do we do it in the fasted state, you know, the intermittent? And obviously, like, I'm only walking, I haven't done anything else. I'm not, you know, so just wanted to get your opinion on that, please.
If you know that you need to lose visceral fat or you need to lose fat off the body, then exercise in a fasted state will give you quicker, bigger benefits. There's no doubt about that. I spoke to a professor in nutrition about this, and when he does the meals for the elite rugby players, what he does is, on training days or days when they've got matches or a lot of physical stuff, that's the days that they get the carbs, and that's the days that they are looser with what they have for breakfast and various things, because they're going to be utilizing it and they need to fill their muscles up with energy. On the days when they're not training, and if any of them are showing signs that they are not meeting their body fat goals on the extended testing, they will have them either fast or restrict carbs on those days, and reduce the energy content of their diet in terms of how much fat they're consuming. So if you want to achieve something in that realm, then it's about being under your calorie budget by 300 or 400 calories, and also looking at your macros on those specific days when you're not exercising, is what I'd say. You're going to get more gain there, probably.
I got an interesting. Sorry, Mark. I was going to give an interesting tip. What myself and my friend have discovered this week. I don't know, I might share it with everybody else. It might help. It's in reducing inflammation and just kind of increasing your metabolic rate, you know. So I had a hip injury where I damaged my hip capsule. So walking and everything was kind of painful. So we get hot water. We've put in some lemon juice, a little bit of ginger, some turmeric, and cinnamon. And apparently, cinnamon is really good for raising your like metabolic rate, and actually maybe even it has some properties on a cellular level. Like there's still a lot of research out there, and we've taken that like first thing in the morning, and maybe like a drink last thing at night. And would you believe, in the last few days, my hips have been far freer than they have been in in months walking. And she has noticed the same thing herself. It's like there's like it's like a freeing up, or else I don't know if there's just like your body feels lighter. And I don't know if that's like if that will help anybody, but it's something that we're just experimenting with.
Yeah,
it's ginger and cinnamon and turmeric and lemon.
Send me the recipe, Faustina. Sounds good.
I will. I post it on the WhatsApp group.
There you go. Let's see if we can get through. Steve?
Yeah, I know everybody's favourite subjective lipids. Is there anything in the standard lipids panel that you think is valuable apart from triglyceride HDL ratio? Is there an upper limit of LDL at which actually it really is a problem now? We know to generally ignore it in this group, I think, but is there a limit to that? Is there anything else in there that's useful?
Yeah, I think I mean, it is all useful really because everyone's different. But you know, I do start to get twitchy about whether there's familial hyperlipidemia when someone's LDL is baseline greater than 5 and the total cholesterol's greater than 9. I think those patients should be tested. Often what you find is that they don't actually have familial hyperlipidemia. They do have a familial combined hyperlipidemia, where it's a multi-genetic thing, and they've often got ApoE 4 in one of the, they're either a 4-4 or a 2-4 or a 3-4, and actually they're just not clearing lipoproteins from the bloodstream very effectively. Yeah, so I mean, I think it's all useful, but it depends on what the patient's like physically. So if they're, you know, very overweight, central obesity, diabetic, fatty liver, and their lipids are all off, then they need extensive work, both pharmacologically and from a lifestyle perspective. But if they're very, very thin, very little subcutaneous fat, and they're exercising and fasting and doing ice baths and just eating butter, which, you know, a lot of people are madly doing, you know, then that's a different case. Their LDL is likely to be very large. The particle number might be low. They might have very low residence times, but again, you don't know. So I've got patients who are like that and their arteries are completely clean, but I've got patients who are like that and they need a bypass, and it boils down to there'll be something else in the deep roots of the genetics, be it apolipoproteins, be it lipoprotein A, be it you know, something else that we don't know about, that's you know, endothelial dysfunction, something else, inflammation, something that's causing them to get coronary artery disease. And there are not many people out there who are absolutely perfect. And let's be honest, if you're a man and you're getting older, you can't escape oxidation. Yeah. And that's one of the things that will happen to your lipids anyway. So I'm still in the camp of trying to get the lipids as good as we possibly can, because you're not going to escape oxidation. If that makes sense.
Okay,
But I'll always look at all of it.
Got 2 more questions, so if we can quickly wrap this up on time for Dr. Scott. Marianne, lovely to see you too.
Thank you. Just a quick question. I'm wondering about the plaque buildup inside of stents. Why does that happen, and what can you do about slowing that down?
Funnily enough, Marianne, I was going to ask the same question if I had the chance.
Great minds think alike.
So this is tied up in how you as an individual respond to the stent that's been put in. The stent industry worked around it, and like after 2010, it tended to be drug-eluting stents that were put in with actually cytotoxic chemicals sprayed on the stents. So the same stuff that you would get in chemotherapy on a stent, in order to prevent the body from overgrowing the cells and reacting to the stent. So that's what drug-eluting stents are. Now, what tends to happen inside stents will be a combination of intimal thickening to start with. So sometimes the body grows its own new covering inside the stent, the endothelium. But if you haven't basically dealt with your primary risk factors that caused you to get there in the first place, then the whole process will start again inside the stent. It just tends to be a more fibrotic process in a lot of cases, so slightly tougher plaques develop. But it's individually different. Some people will have a bare metal stent or even just a balloon angioplasty and go decades without a problem. Some people have a drug-eluting, the newest generation stent put in, and fur it back up within 3 months. We know that one of the main reasons why it happens is diabetes. If you're diabetic and you've got a lot of arterial disease, you're often better off with a bypass.
Yeah, so I had a drug-eluting stent in 2010, and I had a angiogram a little while ago, and it was 50%
Re-narrowed.
occluded, but velocity was fine. And then I
Yeah.
had another one this past October, and it went from 50% to 30%. So I figure I went in the right direction.
Yeah.
So I'm just
okay.
curious about that. And again, no problem with the flow.
Well, I mean, you had probably one of the first generation of drug-eluting stents then.
That's
Because
a while ago.
it was still putting bare metal stents in the late 2008, 2009 because of cost. But from 2010 onwards, it was mainly drug-eluting stents that were going in. And you can always get another stent inside a stent. You know that.
Don't tell me. Don't let my cardiologist
I
know
don't
that.
want, I don't want to do
that. I'll be done for.
It's in
Or
it's
you
in the
can-
LAD, so that's not a place you want to mess around with again.
No, and they've also developed drug-coated balloons now where you can you don't put another stent in. The balloon has a coating of the paclitaxel, which is the drug which stops cells from growing, and you basically blow the balloon up in the stenosis for about 30 seconds, and you give it some time apparently to
Kind of like an
filter through.
aftermarket stent, then basically.
Yeah, yeah.
It's super, Scott. It's been fantastic. Let's try and wrap up with Donnie then. Thanks for that, Marianne. It was right. I was right on the tip of my tongue.
Hey, good
Where you
morning.
gone, Donnie?
For
Donnie,
people
there
that
you
have coronary artery disease and or high plaque burden, what's your viewpoint on the high dose vitamin C therapy?
I'm not convinced. I think you'll end up with a kidney stone. I don't know. There's a risk, and I think is this the Linus Pauling stuff and chelation and all that. I'm yet to be convinced by that. There was in fact, I sent the paper to Mark about there's a recent publication in JACC about micronutrient supplementation and its effect on coronary artery disease and events. Vitamin C didn't make it.
I shared
The only
that.
thing,
I think
the
that
only
was one
things
that
that made it, yeah.
CoQ10, right? It was the
only things that
only...
made it, were vitamin D, magnesium, Q10, various B vitamins. I suppose that will be for your people who've got homocysteine issues, and folate helps reduce stroke apparently. But beta carotene, vitamin E, vitamin C didn't make it, and that was it. It was a huge study. I think there was hundreds of thousands of patients in it now.
I think I did share it. Scott, you've been great, and it's fabulous having you here. And there's one thing actually my darling wife provided me with. It's actually in the Negroni ad, and I just wanted to ask you if you come across it. It's a new type of stent, and it's called where is it? Bio something. Wait a minute.
BioAbsorb or
no, it's a bioadapter. It's a bioadapter implant, which is supposed to be like a stent that consists of a helix. There's less metal there, but it opens up the artery, but it allows the artery to be more flexible afterwards. Okay.
They've been working on this for decades. Oh, by the way, Donnie, just eat more oranges or suck on a lemon or something like that. I don't know if you want some vitamin C. The stent companies are always looking for a new story. So they created a stent that actually disappeared. It was called Absorb, and it was a
I mean, I think this
sort
is probably the brand name of that stent you're about to describe there.
And it was thought to be the next generation of stents, and then when they did proper tests on it, they were finding there was more clots in the stents. So anything that's new or coming out until it's rigorously tested and has been around for 5 or 10 years and shown a massive benefit, I wouldn't touch it.
Okay, fabulous.
Recommend
Thank you, Scott. I think we can wrap it up there. It's been brilliant having you. Thank you for coming back.
Very much indeed. Thank
Okay,
you.
thanks for asking me.
Thank everyone.
Take care. Bye-bye.
Thanks so much. Have a good weekend, everyone, and see you all again soon. Thanks for being here.
Thank you.
Cool.
Thanks,
Thank you,
Mark.
Scott.
Thank you.
Cheerio.
Bye-bye.
Thank you.
Bye.